extensive notes on my slides. And so I'm always afraid that those notes are going to show up, but luckily we got it worked out. Awesome. Let me arrange my screen. Great. Okay. Hi, everyone. I'm very happy to be joining you today. I'm in Nairobi currently, so good evening. I'm looking forward to sharing a little bit about my career journey, my GloCal year, and how that led to my KO1 application and my very recent transition to faculty at UCLA. All right. So yes, I'll start by talking about my career path more generally, and then I'll talk about my current research a little bit, both what we learned from previous work, including when I was a GloCal fellow, and what's coming next. I'll share some thoughts on the KO1 process because I expect that's on the horizon for at least some of you. And then I'll close with some very brief reflections on how I've pursued the so-called work-life balance. I think, like many of you, I knew I wanted to pursue a career in health, very specifically global health, early in my undergraduate years. And I was very lucky to be at Harvard College, which meant I had the access to resources, including summer internship grants, connections to health NGOs that let me explore that interest even as an undergrad. So between volunteering, internships, and clinical rotations in medical school, I spent about 12 months in Malawi between 2009 and 2015. And then I spent 4 months in Mozambique interning and writing my master's thesis on public-private partnerships for health. So when it came time to choose a medical residency, global health was one of my main criteria for the decision, and that made UCLA an excellent fit, especially because I could actually return to Malawi and to Mozambique, which were the places I had worked previously. Obviously, residency is an intense clinical experience, but I was really happy that I had been right, that I was in a place that let me continue to focus on global health. So as a second year resident, I spent a clinical rotation at Partners in Hope in Lilongwe, which is actually now my primary research site. That month was still purely clinical. There was some excellent learning. I'll share this 4 centimeter pericardial effusion as a good example of the really amazing clinical exposure and clinical learning I got that month. But ultimately, the most important part of the month was a 1 hour lunch I had with Dr. Kate Doval, who later became my research mentor. I then went on to do another clinical rotation in Mozambique on the pediatric side. I'm med peds trained, or internal medicine and pediatrics. But then in my 4th year of residency, I was supposed to return to Malawi, but the rotation was canceled due to COVID. So that meant I had quite a bit more time to work with Dr. Doval, which was very good timing as I was getting ready for the job search. For many years before that, I had assumed that my first post-residency job would involve clinical care in a place like Malawi, but Dr. Doval offered me an alternative path. I spoke with her at length during that rotation, that research rotation, about what would be next for me after residency. And she helped me see that my experience in Malawi, combined with the quantitative skills I developed during my master's degree, and then the excellent working relationship that I had with her, could all come together if I pursued global health research. So she proposed that I apply for a T32 fellowship that would let me work with her full time. What she didn't know when she and I were discussing potential projects was that I had this other deep-seated set of beliefs, really radical perspectives on immigration, beliefs about the importance and value of immigration, a conviction that borders should be open, humans should be allowed to move anywhere they want. This was something I believed long before I did anything related to medicine or anything related to global health. And I always just assumed it was going to be this other part of me. It's not a very common perspective, the idea that there shouldn't be borders and there shouldn't be limits on human movement around the globe. So I usually kept that perspective to myself. But as I was talking with Dr. Doval about potential projects, she shared that mobility and migration was playing a big role in treatment outcomes for her study participants in Malawi. She didn't know exactly what was happening or how big a role it was playing, but she felt that there was a worthwhile sub-study to be added to her upcoming RCTs. And this was just an epiphany for me, that these different disparate pieces of myself could be unified in a single research focus and a single career path. So that was the conversation that led me to my current research. Again, this is a big departure from a very clinical trajectory I'd been on before, but it was a very good time for me to take a break from clinical training. I don't know how many of you were in residency or were already practicing in 2020, but those were pretty dark days, and I was not sorry to leave the hospital wards behind. Luckily, I was awarded that T32 fellowship, and then the following year, I transitioned to the GloCal fellowship, and those years let me immerse myself fully in studying how mobility affects HIV outcomes. Our group has come a long way from that conversation I had with Kate 4 years ago when she was kind of suspicious of this role of mobility in HIV outcomes in Malawi, but didn't know exactly what was happening. So I'll share with you a bit about what we've learned since then and where we're headed next. I'll start with some pieces of info that should feel very familiar for anyone who studies HIV, and probably honestly for many of you who don't study HIV. These days, HIV treatment is readily available across the African continent, and many countries are doing very well in getting as many people as possible on treatment. So a number of countries, including Malawi, are on track to reach these 95, 95, 95 targets set by UNAIDS by 2030. But despite this progress, we do continue to see new infections. In part, that's because several key subpopulations remain virally non-suppressed, which means that HIV is still replicating in their bodies. In most cases, that's because treatment programs just aren't working well for these folks. If they were able to stay on meds and take them consistently, they wouldn't have HIV replicating at such high levels in their body, and that would mean that the chance of new infections of transmission would be essentially zero. So as long as treatment programs aren't working for some people, that means that those folks will continue to get sick and possibly die of HIV, and it also means that the virus will continue to spread. One of these groups struggling to remain in care are mobile people. We know from studies across sub-Saharan Africa that at every point along the HIV care cascade, outcomes are worse for mobile people. They're less likely to know their HIV status, less likely to be on ART and retained in care, and they're less likely to be virally suppressed. So we see it, for example, in Lesotho, where migrant workers are 6 times more likely to be lost to follow-up than their non-migrant peers, or in South Africa, where mobility was the #1 most common reason for stopping ART in a 2021 study. And we see it in the Lake Victoria region in Kenya and Uganda. One study found that recent migrants were 2.7 times more likely to lose viral suppression. And another showed that participants, non-resident participants or mobile participants, were 20 percentage points less likely to achieve viral suppression. But one of the key challenges in this field is that mobility is highly variable. So first, that makes it hard to achieve generalizable research results. So the 4 studies I've cited here all use very different definitions of mobility. But second, the many different forms of mobility that people engage in probably don't matter equally for ART outcomes. Traveling for 3 days for a church gathering that you've planned for months is very different from being given 1 day of notice to leave for a 3-month temporary labor contract in another country. Now, this matters because if we want to plan targeted interventions to support mobile people, we have to drill down much deeper to understand who travels, why they travel, when they travel, where they go, and we need to know which answers to those questions matter the most for ART outcomes. And as an aside, the other reason mobility matters and studying mobility matters is that it is continuing to increase. Because of the growing pressures of climate change and the resulting natural disasters, pressure of civil conflict and refugee crises, and of economic inequality that leads to labor mobility, these movements in human mobility are likely to keep increasing in the next decades, probably around the world, but certainly in sub-Saharan Africa. So with that as background, I'll start with what we've found in our setting in Malawi, first with the findings from my first postgrad year. So my main project that year was a sub-study of the 2 parent trials led by my mentor, Dr. Doble. The trials enrolled men living with HIV who were experiencing treatment interruption. They were not currently taking ART. A small proportion of them would have been diagnosed and never initiated treatment, but the vast majority had initiated at some previous time and then had missed a subsequent refill appointment. We looked at both quantitative and qualitative data coming out of these trials to understand what role mobility was playing in men's treatment outcomes. First, we found pretty high rates of mobility. 34% of men with HIV not in ART care reported being mobile or spending 14 nights or more away from home in the past 12 months. And second, mobility was essential for these men. Most travel, more than 2/3 of their trips, was for income generation, usually for ganyu or piecework, which is temporary informal labor contracts. The second most common reason was for unplanned social obligations like attending funerals or caregiving obligations for family and friends living away from home. And more than 1/3 of trips involved cross-border travel to Mozambique or Tanzania, which is more common for income-generating trips. And given the vastly different health systems in rural Mozambique compared to rural Malawi or southwestern Tanzania compared to Malawi, these border crossing experiences had big implications for men's ability to stay in care. Our qualitative data was especially rich. Again and again, men talked about how mobility and ART adherence were in conflict. Though they almost always brought their medication on their trips, they often ran out of pills or missed refill appointments while they were away, especially because trips were often unplanned or lasted for an unexpected length of time. This conflict was worse for some men than others. So, men who felt fear of disclosing their HIV status in their destination, and men who traveled to other countries, as I mentioned, had a harder time staying in care. But even for men who remained in Malawi, it was often difficult to access what are called emergency refills in their destinations. And finally, after men returned home from traveling, it was not, especially if they'd missed an appointment, it was not always easy to return to clinic, especially if they feared being yelled at or treated poorly by providers. Once the trials were over, we returned to the quantitative data to dig deeper into what types of mobility mattered most for outcomes. This was the research that I started as a GloCal fellow. So we looked at what types of travel led to bad outcomes in the trial, specifically a repeat interruption in treatment. And I used multivariable regressions and area under the curve analysis to drill down to what types of mobility were high risk or highest risk. And we found that taking any trip over 30 nights or any trip that lasted unexpectedly long seemed the most strongly predictive of men falling out of care. So using that definition of high risk mobility, it matters a lot for repeat interruption in treatment. Men who experienced high risk mobility were 20 percentage points more likely to fall out of care. And when we adjusted for other factors, the odds of repeat IIT were more than twice as high for men with high risk mobility. Now, this is not so groundbreaking, right? Taking long, unpredictable trips is, of course, going to affect men's ability to attend ART appointments. But it was really valuable to actually get a quantitative assessment of the impact that mobility has, because if you're going to try to draw attention to an issue that policy could address, I think understanding the magnitude of effect and the impact this was having on men's lives and on men's ART outcomes was really important. However, there were some big limitations with these studies. So again, this was a sub-study of an RCT that my mentor was running. So these were men participating in a trial. They were being exposed to interventions that were supposed to improve their ART adherence, but they were also recruited in ways that do not reflect the standard of care. So they were traced at home rather than looking at men who sort of willingly attended the facility on their own volition. Most of all, they were all men who we do have good data to suggest that men are experiencing the brunt of mobility associated interruption in treatment, but they certainly aren't the only people who travel. So my other main project as a GloCal fellow was securing funding for another study that would ask similar questions of a more generalizable population. So for this study, for IRTI, we enrolled a prospective cohort of about 900 ART clients who were initiating or reinitiating ART after a missed appointment. And in this study, we recruited participants from the queue. So unlike the previous trials, which men were being traced at home, this one, we're only looking at folks who have come to a health facility on their own accord. We felt this would better reflect any potential interventions that the health system might apply, because it is expensive and hard to trace men at home, but very reasonable to offer interventions to people who have shown up at the facility. So we just wrapped up enrollment in April, and we're going to be starting chart reviews in just a couple of weeks, like 2 weeks, to look at 6-month retention for this cohort. Our hope is to use the data to predict, not just to look retrospectively, but to predict who's at risk of treatment interruption so that they can be offered services before they miss appointments. And designing these services to reduce mobility-associated interruption in treatment is the focus of my KO1 grant, which just formally began last month. My KO1 application described 3 pillars of an intervention that we think will help to reduce these missed appointments and these treatment interruptions due to mobility. So first, we want to offer what we call enhanced multi-month dispensing, which is really just ensuring that multi-month dispensing is offered to mobile folks, which should make it possible that even if men and women have these long and unpredictable trips, that they should be covered for more of their travel and have fewer opportunities to miss appointments. We also want to offer a mobility hotline. So the idea with the hotline is that mobile clients can call to troubleshoot their particular situation. Maybe they're leaving on a trip on short notice and they need to get permission to get a refill at their facility before their usual appointment date. Or maybe they're already traveling and they are running out of pills, or they're about to miss an appointment or did miss an appointment, and they need to know where to go and what to do to get back in care. And finally, we want to offer mobility specific counseling for folks when they initiate or reinitiate, again, to prevent these interruptions in treatment. And we think we can help them draft these personalized plans to continue ART while they're traveling. Now, actually, let me go back for a second because this is the intervention as I proposed it, right? This is a screenshot from my proposal. But this is quite likely going to change before we actually offer the intervention. Right now, I'm working on analyzing data from healthcare workers that may change exactly what we offer and will certainly change how we offer it. I think we actually need to address some systems issues as well, things like recording and reporting data, some deficiencies in the electronic medical record system, so that it's easier for providers to welcome back clients after they've missed an appointment. So this is what it looked like in my KO1 application, but I think the actual pilot trial, which hopefully will start next year, will evolve and look a little bit different. Okay, so that's the work I did as a GloCal fellow and a quick preview of what's coming next for our group. But unless you happen to be very interested in mobility or in HIV treatment outcomes, I think the next slides are going to be much more interesting. I'm going to talk about my KO1 application process and some lessons that I would share with someone getting ready to apply, which I suspect includes a number of you.
Yeah, so
So first, yeah,
I'm gonna change the process a little bit, given that you're switching to your career talk.
yeah,
So at this point, I wanted to invite folks to reflect on the project that Marguerite, Dr. Thorp just presented and ask some questions. I have a couple, but I wanted to, I think we're doing really well on time, so feel free to
great.
put it in the chat or unmute and ask away. Okay. Oh, go
Hi,
ahead, Joe.
Marguerite.
Go ahead.
Um, my my question is a little bit about your like data statistics side of things. I think
Yeah.
your background is like pretty impressive in that analytical and like quantitative thought process to some of these like culturally difficult real world problems. Have you found any like analyses or like a time run analysis or something that you really like that you think um fellows or people getting in the field should try and like look into as like good ways to try and quantify a lot of these like difficult cultural things that you've really enjoyed, your data analysis type of things?
Yeah. Oh man, that's a great question. I think so. If I'm understanding what you're asking, like, how did my group and what would I advise for someone try to capture complex social phenomena and turn it into like lines in a regression table, right? Um, yeah, I think uh, there's the answer that I would give if I were teaching a research methods class, and then there's like how some of the other ways we actually went about it. So I'll start with the formal answer, which is really using qualitative data to inform our surveys. I didn't kind of talk too much about ends here, or let me scroll. Yeah, actually, I just missed it. Oh, that went way too fast. Sorry if I'm making anyone dizzy. This is the one I wanted. So these qualitative findings we drew from 36 in-depth interviews with men that were participating in my mentor's trials and had answered some survey questions suggesting that they had done some traveling. And this was a beautiful and rich analytic process for us. Like this was new, these were new questions we were asking. There was very little data on men's mobility in Malawi. There was very little data on mobility in Malawi, but even less on men, actually. So we were exploring new topics for the first time, and in-depth interviews, qualitative data is probably the best way to go about asking those questions. And it was out of that kind of grounded theory and that like really rigorous qualitative process that we developed much better quantitative data, quantitative survey questions. So that's why we now ask about individual trips instead of asking about like a total travel history, because we know individual trips are very different. It's why we ask about how much planning men were able to do, about how long, whether they knew how long the trip would last before they took it, was because of what they told us in their in-depth interviews. So using qualitative data to inform quantitative data, I think is my research methods class answer. The other answer, though, is that we did a really bad job before we did a good job. And that our first surveys and our first survey questions were messy and the questions did not all work. And we got bizarre data coming out of some of the early surveys. And we realized we were only asking about, like, the way we were asking questions about travel, we were only capturing a small subset of what was happening. We were only asking about long trips, which probably matter most, but like we just believed that on a gut feeling. We didn't have good data. Maybe short trips do matter, especially if someone's taking a lot of short trips. We didn't ask about trips less than 14 nights in our first rounds of the survey. And so we had to do a bad job before we did a good job. And like we just learned from early survey drafts. I think pre-testing with your research assistants who are going to probably know the context better than even your study coordinators. I think piloting for a day or two before you launch a survey, and then ultimately just being ready to do multiple rounds. And like the arc of research is long, and we were a lot worse at this in 2021 than we are now. So it takes time. Hope that's helpful.
Yeah, well, thank you. And go ahead, Greg.
No, no, that was perfect. The question was a little weird and vague, but your answer was, you summed it up perfectly, and your answer was really helpful. I appreciate that.
Yeah, so just want to say congratulations on your career path so far, and I'm really excited for your, KO1. And so before we go on, just had one quick question about your project, your KO1. So looking at the intervention arm and the standard care. So
Yeah.
thinking about, so this is currently being done in Nairobi, you said? Or
In Malawi. This will all be
Malawi?
Malawi.
Okay.
Yeah.
So you're currently in Nairobi.
I am. I'm going to talk
Okay.
about that at the very end. But
Okay,
yeah, that's
gotcha.
right. I live in
So
Nairobi, but my
yeah,
site is in
so I
Malawi.
think kind of reflecting on, so obviously this is gonna be implemented, and thinking about potential like policy changes in Malawi. And
Yeah.
I guess my question is about the current standard of care. So for example, do they even
Yeah.
have like mechanism where you can do emergency refills, or is this only gonna be supported through your K? And if so, then I think it kind of underscores like need for policy changes, right? So
Yeah. Yeah. That's a great question. Well, and this was actually an interesting challenge of writing the K because on paper, the policy environment in Malawi is quite good.
mm,
There is still a big deficiency of not having integrated electronic medical records. So, like a lot of these challenges could and will eventually be solved when health facilities have interoperable medical record systems. If I could write a K on that, I wish that were possible. I wish that were like feasible within the scope of the K, because I think that's the kind of big picture change that is going to really address these
mm,
problems. But aside from that clear deficiency, the on paper things are pretty mobility friendly, I guess, in Malawi. So it is possible to get a 1 month supply of a refill from a facility that is not your home facility. It is possible to get pre-travel refill. You can show up at your home facility before a trip and you can request a refill early on. I actually don't think that's like explicitly written in guidelines, but there's nothing against guidelines. And so it is a practice that is possible. And probably the most used practice is a guardian or a caregiver refill. So folks will ask their wife, sister, child, mom, friend to pick up a refill for them. And even we've got some really interesting stories of even while folks were traveling, they would have someone pick up their refill and then send it via minibus, sometimes all the way across the country, and like they would somehow manage to transport it even to pretty remote areas. So those are all possible and they would help address this issue. But what we find is there are a lot of challenges. So obviously the caregiver guardian refill, like the pills still have to get to someone. The emergency refill, we found a lot of cases where folks had attempted to get an emergency refill, but they were turned away.
mm,
Either there was some either deficiency in their health passport, like in their personal medical record, or it may be some kind of reluctance and resistance. We think that healthcare workers, it's a not a well-documented process. And so I think healthcare workers often feel like even if it's in the guidelines, it doesn't feel like an official way to give someone a refill. And a lot of folks being told you need to go back to your home facility, get a transfer letter, and then you can return here and refill, which is crazy for someone who's on like a 3-month work contract, right?
Yeah.
And then the big one that we're actually engaging with the nuance of in my application is multi-month dispensing. So multi-month dispensing is available in Malawi. 6 months is possible if you're stable in care. They actually just changed guidelines a year or two ago so that 3 months is available if you are reinitiating care, if you don't have any clinical symptoms. But what we find in practice is that it is very rarely offered. 6-month MMD is doing a little bit better now, but again, only in those like stable clients, which usually are not mobile people. But offering 3 months on reinitiation, there's very low rates of that actually being offered. It's allowed, but it is rarely practiced. So part of what we're doing, and there's like a little bit of an implementation science-y feel to some of this, is just trying to figure out how do you get guidelines, how do you take all the flexibilities in the written guidelines and actually get them practiced in a facility setting.
Great, fascinating. Well, thank you. So we can proceed to your second half.
All right. Okay. So the first step that kind of before I think anyone actually puts pen to paper for a KO1, I think the first thing I would recommend is being very, very clear in where your eventual academic home is going to be. So specifically, this means who is going to write that academic support letter that has to accompany your application. You need this to be explicit. You need it to be certain. You need to be really confident in this, that you're going to have a department chair writing a letter to apply when you apply. Maybe very simple for some folks, but it also may be very complex. Kind of the cautionary tale, and the reason I wanted to include this slide is a friend of mine in a different postdoc program had a lovely K application ready to submit, and just couldn't find that home at her institution. And so she ended up 3 years of like struggling to figure this out, and an institution change later, finally being able to submit, and she did receive her K. But I think the goal of finding this home and this academic destination early on is really important. And you want to know what these department chairs are going to need from you to be able to support you. So maybe that means you have to do a formal job talk application process. Maybe it just means you have a Zoom call and they get to know you. It's not always transparent. It's highly variable, but it is probably the most important thing to start early because it will be the bottleneck. It will be the door you can't pass through later on if it's not figured out. And the reason I put the soft money title or concept up here is something I hadn't heard this term before my own KO1 application and an appointment process. So it essentially means that your faculty appointment will be contingent on receiving continued outside funding. Usually NIH, sometimes Gates or other funding, but like you need to bring in the money that pays your salary. I think this is pretty common at medical schools, maybe fairly common at nursing schools. I'm not sure about other health science schools, a little bit less common maybe at schools of public health where there's more like support for faculty members. But it can come up a lot in medical schools. And so I think being aware of this and being aware of these requirements early on is really helpful. What it means for the KO1 process is that advancing to faculty will often be dependent on receiving the KO1. Officially, the NIH discourages this, and the departmental support letter shouldn't describe this like threshold process explicitly, but I think you will find that it's very common at many universities. So once you know where the home will be, you can start assembling your team of mentors. The core mentors, which mine are right here, are very likely to be your GloCal mentors, but you will probably need more folks. So in my case, I added on a very senior mentor, Tom Coates, many, many years of NIH funding, many K mentees under his belt. And then I added a biostatistician, Jihong Seng, and I added a UCSF expert on my content area on mobility and HIV, Carol Camlin. Now, some mentors are going to be really heavily involved, reading many drafts of your application, and others will look once or twice and only at portions, maybe only at your power calculation, for example. But this is totally fine. That's why you have a big team. The challenge that I found, I'll talk a little bit about, is that among these very involved mentors, there are often very strong and sometimes conflicting opinions, which is good. That means they're engaging and supporting, but it can also be a challenge when you realize you might have to say no to some of these people you really respect because you're going to choose a different route. And then finally, I do agree with the advice that you need one of these very senior members of your mentorship team. I remember hearing jokes about how every K application needs an older white male. And I think that's because of what research faculty looked like 30 years ago. But luckily, I do think this is a fading reality. I think eventually we're going to have plenty of senior mentors available who look like the much more diverse community of global health researchers today. But for better or worse, I think it's not uncommon at this point. Also, just very briefly wanted to mention, there are a lot of K grants out there. I also didn't know this. I really only knew people with K01s, and so I didn't understand how much else is available. Very important for this cohort is the Fogarty Center's K43, which is available to non-US citizens or permanent residents. But also K99 R00s, usually designed for projects that are almost ready for an R01. Those are also available to folks that are not citizens or permanent residents. If you are, however, a citizen or permanent resident, it's worth exploring which one of these other Ks might make sense for you. So yes, K01 common, I think there's usually the most dollars attached to that. But you may find that a K08 for more bench research, K23 for more patient-oriented research, or if your project is pretty advanced, that a K99 or R00 may be worth considering. Okay, so briefly back to my K01. Every application is going to include a research proposal that should be pretty closely tied to a training plan. I submitted my K with two specific aims. First, intervention refinement with providers, clients, and a community advisory board. So again, I think I know what I'm going to do, but my aim one is what I'm engaging in right now, which is drilling down and refining that intervention. And then aim two is going to be a pilot, a 3-facility pilot in a cluster randomized control trial. And that should hopefully give us the preliminary data we need to apply for the large scale, call it definitive R01. My training plan focused on 4 aims: health system interventions, obviously that's what I'm doing, trial design and analysis, which is going to be for me advanced biostatistics, interventions for mobile populations, and global health ethics and decolonizing global health. So brief timeline preview. So I started my GloCal year in July 2022, and I submitted my first application in March for this Fogarty deadline. About 3 months after that, I got my score back, and then got comments a couple of weeks later. So also worth noting, this March deadline is the only Fogarty deadline of the year. Most other agencies have 3 deadlines, but Fogarty just has the one for its K. So what actually happened in those months? So from July to October, June to October, I was really conceptualizing the idea, talking with my mentors about big picture, what might the application look like. November and December, I was doing very detailed outlining. I'm someone who has like a bullet point outline before I ever write a full sentence. And then January and February, I was drafting in earnest, really not doing much else. Submitted in March, scored in June. And when I got that score of 46, it was pretty clear that I wasn't going to be funded on that round. Just a side note, you want a low score. So you need something in the 20s or below to be really confident in funding. Sometimes in the 30s, you might have an opportunity, but with 46, it was pretty clear I wasn't going to be funded on that first round. But getting a score was great. Only about the top half or so of applications get those scores. And if you get a score, it means that you're going to get detailed comments from 3 reviewers. So you're going to have a lot of material to go back and modify your application with. I think the most important lesson I learned from this was that it was okay that my aim one is exploratory, but the way I wrote it in my first round, it was too exploratory. You need a lot of detail of what that pilot is going to look like for, I think, reviewers to be comfortable with it. And then in terms of process, maybe more applicable, even if you think you should be able to accomplish other goals and other work while drafting the K, it really can take up all of your time. The training and research plan can just be infinitely detailed, and there are so many other pieces, parts. There's the human subjects, there's all of the budget and the corralling of mentors to get all of their documents. I really did very little other work in January and February when I was in the final stages of preparing the application. So once I had my comments, got those comments in July, I tried a major revision in August and September, Sent it to my mentors in September and they came back and said no thanks. So October and November, I went back to the original and focused more on smaller tweaks rather than doing like a big redesign. Spent November really revising that language, and then December I used to update the other documents, as I mentioned. I was done with my pieces over the holidays. UCLA submitted on January 7th. And then I got my score in March. And this time with a 15, I knew with quite a lot of confidence that I was going to be funded. So big lessons from revising. Again, number one, strong mentors have strong opinions, which means that sometimes they're going to conflict. I started the process really trying to accommodate everyone's suggestions, and then ultimately I learned I had to say no to some ideas. Painful, but very important. And finally, if you're staring down this process and you're like, oh my God, it takes 2 years to get this grant, like that sounds exhausting. Round two was way more enjoyable than round one. Revising was way easier than starting from scratch. And even while I was doing all this revising, I was still able to accomplish other research goals, which had not been true when I was writing the first round. So going back to our timeline, so got my scores and comments June, July 2023, used the next few months and resubmitted in January, got my score in March. And then it took about 5 months in my case to actually get that notice of award and trying to transition to faculty on September 1st. So those 5 months, I didn't necessarily expect how long it would take. I should have, but I didn't. If you are approaching this process, I think it's worth noting there's actually a lot of work between getting the score and the grant period actually starting. Most of it falls on you, the applicant, but there is a lot that your university officials have to complete as well. So you'll do just-in-time info. You'll have to get IRB approval. They're being more strict these days, as I understand it, of actually getting IRB approval, not just submission. And it'll be important to have a good plan in place for how you're going to be employed and funded during this period. And finally, if you are scoring in higher scores and like in the more borderline scores, like high 20s and 30s, this process could be even longer, and you may actually have to wait until the end of the fiscal year. You may get a lovely notification of funding at the end of the fiscal year that you weren't expecting, but that could be as much as 9, 10, 11 months after you submitted your application. Okay, so I wanted to close with a couple reflections on work and work-life balance. Obviously, all of this research depends very minimally on me, but really on the excellent team I work with in Malawi. So research coordinators, field assistants, and all of the collaborators I have there. I'm lucky to have a co-PI there, Kelvin Balakasi. We've been able to get funding together. We're collaborating on the prospective cohort. We're co-PIs of that study. And he's been an amazing kind of peer mentor for me. I've also gotten to collaborate with a group of Kenyan researchers, initially connected through my mentor, Dr. Camlin, and understanding how their collaborations work, these sort of UC to Kenyan collaborations has been really valuable as well. Now, one of the reasons I got involved with the Kenya team, in addition to working with Dr. Camlin, is that I do actually live in Kenya, and I have since 2021. My husband and I had expected to move to Malawi when my postdoc started. That had been the goal. But despite his valiant efforts, he was never actually able to find a job in Malawi. Applied for lots of things and just kept meeting with closed doors. But Nairobi, very different, has been a really fantastic place for his career to progress. And that means I'm a 2-hour flight away from the long way. The other upside, in addition to having his career progress, is that in Nairobi, there's just phenomenal medical care available, and I was able to deliver our baby here. So splitting my time between Malawi and Kenya was easier before we had the baby, and I was spending 2 to 3 weeks every other month in Malawi. Since my daughter was born, travel's been less frequent. This year, I'm looking to be in office in Malawi for about a week, about every 3 months or so. Trying to time those trips around study milestones, like when we train our research assistants or holding stakeholder workshops. So I want to talk briefly about what has worked well for me working with my research team remotely. As GloCal fellows, you are in office and in person most of the time, but if you continue the career, you might not have that opportunity in the future. So what's worked well for me with this distance, first is what I call over communicating. So sharing updates and progress reports as often as possible, more often than you think is probably appropriate. Email, WhatsApp, frequent calls, all of the above. The second is, I used to call it love bombing, but I guess that means something different now. So it's really smothering my team with love. When I'm in country, I'm having as many meals as possible with the folks that I work with. I'm trying to get to know them as well as I can, their family, their kids, their hobbies, because I don't have all of those small opportunities on a day-to-day basis to form strong relationships with them. And then finally, I cannot overstate the importance of really doing your homework about your research setting. So I'm lucky that though I'm working remotely, I had quite a bit of formative time in Malawi and time when I had fewer responsibilities and could be learning Chichewa, reading the newspaper, really trying to learn as much as I could about the setting, well before I knew anything about the health system there. The devaluation of the Malawi kwacha last year had a bigger impact on my research participants than probably any intervention I'm going to launch. And having that sort of tacit knowledge about a site is essential to doing good research. Okay, finally, a quick kind of peek behind the curtain of this otherwise nice and tidy timeline, which is that I had a baby in between my first and second KO1 applications. It was actually the last week of my GloCal year. And in hindsight, it was a little wild to have an application just before becoming a parent and then another application just after. And it being able to do that really depended on having a team at home as much as it did having a team at my site. And I have a really great team. So I've got my husband here. I've got our nanny, Rafa, in the center. Um, oh gosh, I didn't think this would make me emotional to talk about, but and then our new housekeeper, Irene. These are the folks that make it possible for me to focus on my work and still be the mom that I want to be. Um, it would be just irresponsible to talk about work-life balance without talking about them, and also talking about the value I get from being in Kenya. So I couldn't have had a baby as a postdoc if we were in Los Angeles. Between my husband's nonprofit salary and a postdoc salary, we couldn't have paid rent and childcare, right? But being here, it means that I can afford really extraordinary quality childcare. And every new family pieces together this support network somehow. It's often family members, grandparents, it may be friends and neighbors, or in our case, it's professionals. It's folks that we pay to help us make this all work. It just feels really important to me to acknowledge that none of my career success would have been possible without the folks on this slide. And I think, if you want to take the Q&A that direction, I think there's a broader conversation to have about how it is Rafa and Irene's work that makes my work possible, and what that says about global inequality. And I think it can be very interesting, but I'll let you guys decide if that's the direction you want to take the conversation. So I'll close with some shameless photos of my daughter, so we all come away with nice, warm, fuzzy feelings. A final reflection I want to offer is that I hope we all take the same approach to falling down, clapping for ourselves, and getting back up that my daughter does.
All right. Wow. Well, thank you so much. This was amazing and very inspirational and very personal. And yeah, thank you for sharing your journey. And I am sure that our colleagues here will have some questions. So we have time for questions for Dr. Thorp.
I didn't really have a question, but I just wanted to say hi to Marguerite. She's been very helpful to me. I'm also Dr. DeVel's, she's my mentor, and Marguerite has shared resources and templates and all kinds of things, and you've been very, very helpful to me, and I just want to say thank you in person. Person-ish.
That's very kind. Yeah, it's gosh, I probably should include this on my K advice slide, but no one does any of this work without templates and models ahead of us, right? Someone else's grant application, someone else's materials ahead of time. So
Oh,
happy
yeah.
to pay it forward.
Thank you. I'll remember that, and hopefully I can help somebody else in a couple of years.
Definitely, definitely.
Any other questions or comments or?
I have one.
Yeah, go
Hi,
ahead.
this is Mariah. It sounded like I was here listening to you talk about kind of your progress or like your activities and the timeline of your the development of your first KO1 submission, and it sounded like you spent a lot of your GloCal year actually just working on that. I was wondering how much of your GloCal year was working on like a research project, and
Yeah.
how, like, more broadly, I think, like, my question is, how do you kind of balance working on multiple different kinds of things at the same time? I feel like that's a big challenge for me,
Yes.
like working on a proposal at the same time that I'm writing up the paper from the last study, and also planning, like, writing SOPs for the, study that I'm doing right now. And like,
Yeah.
it's keeping a lot in my head at once. And I'm just curious, like, how you have approached that.
Yeah. Oh my gosh, totally. Yeah, I got some good advice early on about that because I don't know about you guys, but I remember the first few months, especially leaving clinical work and then starting research, I was like, I have so many hours in the day. What am I going to do with myself?
Mm.
And then and then by the time I was in the GloCal year, I was like, it felt like these multiple balls in the air being juggled at any one time, right? So the advice I got was that you sort of for your career always want to have a full pipeline. So you always want to have a manuscript that you're putting out, as well as a conference abstract that you're writing, as well as data that you're analyzing, and studies that are collecting data actively and that you're planning and that you're applying for funding for. Like the kind of ideal way to make a career out of this is to have something in each of those buckets at every moment, which yeah became really daunting for sure. I think the way that it when I was doing it best, like when I was really firing all cylinders, feeling like I was like really moving things along, it was honestly productive procrastination. It was like, oh, I'm feeling a little bit daunted by this piece of my KO1 like revision process. But I have an SOP that I can work on. Like that feels tangible and nice. Or like, oh, I've got this sticky problem in Stata that is just really, I have Googled everything I can and I just can't make it work. Let me take a break from that for a day and go back to my K. I think that's when I'm doing it best. It's that like productive procrastination. It's using each task to keep moving forward. Even if like what I'm letting my brain do is put off the things that feel hard to do. That obviously doesn't work if there's one thing that feels especially terrible, and so you're always putting off the grant application because all you want to do is analyze data. Then like the system doesn't work that well. But a lot of self-monitoring, self-check-in, and then just extensive to-do list. I keep, oh gosh, I almost wonder if I should share my screen, but I keep like a monthly, I use stickies on my Mac and I keep a monthly, weekly, daily, I have a sticky note for each of them. So this was a friend of mine works for a pharmaceutical company and he convinced me that I should take this approach to time management where like the first 5 minutes of every hour, the first 15 minutes of every day, and the first hour of every, I think he says week, but I do it more like first month, is all spent planning what you're going to do for the rest of the time. So each day I'm looking at my day to-do list, I'm referring back to the weekly and the monthly, and each week I'm looking at the week's to-do list and referring to the monthly, and then each month I'm looking at that month to-do list and making sure it matches up with my like Gantt chart goals for the year. Um, I think those are sort of, that's the practical tool that I have to stick to make that productive procrastination work. But you also asked about what I was doing during my GloCal year. So yes, to be honest, in January and February of my GloCal year, getting ready for that March 7th deadline, I was not doing much else. I was just getting that KO1 application ready. The nice thing was that because much of the data analysis I was doing as a GloCal fellow was based on my mentor's trials, I had less responsibility in terms of data collection and like study implementation. And so with data analysis, I could just kind of press pause on it. I think I did submit some IAS abstracts, so I must have done something in January, but like February was definitely all K. And because yeah, the data analysis stuff I could shift that until after the K deadline. And then once the K was in, I could focus on kind of making up for lost time and trying to actually analyze data and move forward on manuscripts.
Okay, that's very helpful. Thanks. I would love sometime maybe to see that your sticky note system. It sounds
Totally,
really
yeah.
that itself sounds kind of daunting to me, but I'm just curious to like see always how other people manage their time, especially with so many things going on in parallel. So yeah, thank you.
Yeah. Yeah, thank you, Marguerite. I love that term, productive procrastination. So I should exercise that too. So have a question about the statement you made about having strong mentors and have conflicting advice.
Yeah.
So I guess in terms of your sense of self and your courage to say no and the potential consequence of not listening to someone's advice and the potential implication that would have on, for example, your K award, right? So how did you navigate that?
Yeah. This was a big growth experience and growth area for me, and will continue to be. I'm sure it's not like I solved this challenge, but I like to think of myself as very coachable, and like I love feedback and I love responding to feedback. Um, uh, and what that meant with six very different mentors, folks with very different training backgrounds. So, I've got an MD, a biostatistician, I've got some more public health folks, I've got it's a diverse group. They all gave me great, not all, but the core ones really did give me great feedback, detailed feedback, and I loved responding to that feedback and fulfilling their wishes. um, and what that meant is that there were both in the first and the second round of my K application, there were like very Frankenstein looking applications. Like at one point, I had um, three different theoretical frameworks. All of the, like I was trying to talk about implementation science and differentiated service delivery and Anderson's model of healthcare. Like I, it was so full of buzzwords that it really wasn't clear what I was going to be doing with the work. Um, and luckily, Dr. Doval, my primary mentor, kind of called me in on that and was like you've done so much to meet the expectations of everyone on your mentorship team that like there's nothing here. Like this is like just so buzzwordy that it's not clear what you're going to do in your study. And so I had to take a break from having calls. I found that like having calls with everyone on them, these were senior, really brilliant faculty members, and they could talk. I was hoping the calls would help them like talk to each other and resolve differences, but it usually just left me with like a laundry list of changes that I should make that didn't always like fit together at all. And so I had to take a couple of weeks without actually getting any feedback, and really like center on what I wanted to do, what I thought the intervention was. Because as brilliant as all of them are, I was closest to the data. I'm closest to the intervention that we want to pilot. Um, and so taking a break from calls and then only asking for feedback on sections from each mentor was really helpful. And just like steeling myself and having the courage to say like, I'm really sorry, Dr. Coates, I'm not going to include that. And I'm really sorry, Dr. Camlin, I'm not going to include that. You can do kind of like the feedback sandwich. You can be like, I'm not going to include that, but I loved your idea on XYZ, and that's going to end up in the final version. But still the saying no and the like pushing back against folks that I respect so much was a growth area for me.
Yeah, thank you. Yeah, I think it's a lifelong journey that we have to navigate, right? So I think it's a really good lesson for all of us, including our colleagues here. So we have less than 3 minutes. Any last comments, words for Marguerite? And Kimberly and Julie, do you have any announcements or anything?
I don't think so. I mean, we're going to be starting our works in progress also in November. So the next time we'll be seeing all of you will be the first Thursday at at 7 a.m. our time, but we will have gone off of daylight savings time. So hopefully we'll be showing it's actually the same time as this.
Okay,
I think I've calculated correctly. Anyway, yeah, that's it.
that's great. And then do we have career development series in November as well?
Yes.
Okay.
So that will
Awesome.
be 2 weeks after. Yeah.
Great. Well, thank you all, and thank you, Marguerite. This was really inspirational, and I love learning your work and your journey. Thanks.
Yes.
Thank you.
Thank you,
it's a pleasure.
Marguerite.
Thank you, guys.
That's great.
Thank you.
Bye, everyone.
Bye, everyone.